It's my pleasure right now to introduce Dr. Purna Kushalnagar. She is a Strategic Research Officer and Chief Research Officer for Gallaudet University and directs the Center for Deaf Health Equity. She's the principal investigator of grants funded by the NIH that total close to $15 million. These grants support studies aligned with her primary research interests in health disparities and preventative cancer interventions. In addition to directing the center, Dr. Kushalnagar serves as a research mentor for trainees supported on diversity grants. She will be presenting, "Is this inclusive of deaf, blind, and hard of hearing patients?" Purna, please take it away.
Hello, thank you. I had to join early this morning here, so I'm happy to share our work with you in regards to telehealth accessibility for the deaf, blind, and hard of hearing patients. So in general, the population in the US compromises there's various people who identify as deaf, blind, and hard of hearing who are in the community. That some people are born deaf, some are born deaf blind, and about 22% of people, there are a lot of people within our community who are late deafened later in life. Some are have normal hearing when they're born, spoken language. It varies throughout the US. So that impacts how they access technology as well. And so I'll be discussing that in my presentation today. So before we talk about telehealth accessibility, I want to talk about the assumptions about people who are deaf, blind, and hard of hearing in regard to limitations to accessible healthcare. And I want to remove those biases so that we can focus on healthcare for the community. Some providers may have a perspective that a deaf, blind, or person is different from the normal population. And we're focusing on this patient-centered care in this slide. So we want to take that perspective, and I'm curious, when you look at that person and you look at their background, every person's background is different. You look at the community that is deaf, blind, and hard of hearing, you may think that they have low health literacy. And maybe they don't seem interested in improving the communication. For example, you look at them and they've used sign, maybe they have a cochlear implant, they use a hearing aid, and they speak. And so the perspective is to rely on that verbal communication, and that assumption can be made. And it can impact the patient's education, can impact the communication as well. And maybe the doctor doesn't take the time to educate the patient about their health issues, and that will affect their quality of care. So some of the assumptions, that people use cochlear implants or hearing aids or something, that might affect their viewpoint as well. And the assumption impacts them in terms of being able to understand the various treatment options. And that can apply both to in-person healthcare as well as through telehealth medical care. So right now, this is what we recognized throughout. So in general, these are the social determinants of health that impact their care. Language deprivation and communication are separate but related constructs. Oh, interpreter, hold on, please. The impact of their care in the general population that includes education, economic variance, their social environment, transportation, housing, all of that in health for the deaf, deafblind, and hard of hearing community. There's one more social determinant of health that is very important to their healthcare literacy, and that is language deprivation and communication. Interpreter, let's go back. The importance is to their health literacy, to their health outcomes, interpreter correction, to their health outcomes. In regards to their health outcomes, it's important that we must consider the role of language deprivation or communication neglect. Can show up when a deaf person is in an environment that is not accessible to them while they're growing up. If they're not exposed to a fully accessible language, that impacts their knowledge, their education level, and ultimately impacts their health outcomes. So this definitely would require several presentations to cover. So now I have this video presentation. This is a deaf attorney. They themselves are involved in telehealth advocacy for the deaf, deafblind, and hard of hearing users. So this has captioning.
I do policy research reviews and the Administration for Community Living, ACL. ACL's mission to maximize the independence, well-being, and health of older adults and persons with disabilities across the lifespan. Opinions expressed here otherwise are those of the speakers and not necessarily reflect the views. The HHS, nor should they be construed as legal advice. I will start with a quote. In 1990, the House Committee on Education and Labor, when discussing the eventual passage of the American Disabilities Act, expressed that the types of accommodation provided to keep pace with the rapidly changing technology of times. Fast forward to today, we have 3 laws that address that of the changing technology healthcare, such as telehealth, TH. The Rehabilitation Act of 1973 requires non-discrimination, disability, and programs and activities that receive federal financial assistance. The ADA of 1990 applies to private and state and local government, healthcare providers, including hospitals, skilled nursing facility, urgent care centers, physicians, dentists, mental health providers. The Patient Protection and Affordable Care Act, ACA of 10, Section 1557 prohibits discrimination against race, sex, ACA covered health programs or activities. In general, the law definition disabilities and physical or mental conditions that substantially limits one or more of the hearing or hearing, seeing, walking, or operation of bodily functions such as immune system. A record of such a condition being rewarded as such. Department of Justice, the DOJ, and Guidance and Settlement, the website that includes people who are deaf, blind, and individual disabilities defined in the law. HHS, OCR, and DOJ release guidance on how federal disability law is able to telehealth programs and activities. The document includes explanations on effective communication and reasonable modifications as they apply to telehealth. For effective communication covered shall be appropriate steps with individuals and disabilities, as well as companions and disability communication with both are as effective in communications with others. This includes providing appropriate auxiliary aids and services, AAS, when necessary. The type of AAS needed will depend on the type of communication the individual uses. Also, the communication length, complexity, nature, and context. Examples of AAS that people are using may use to include the deaf, deafblind. Qualified real-time captioning, accessible ICT. ICT can include applications, website mobile applications. An example scenario, a dietitian who uses a board platform to send written to the patients may need to make sure, and the screen reader's capability for patient who is deafblind. Reasonable modification means changes to policies, practices, procedures to avoid discriminating on the basis of disability. Example of reasonable accommodations, telehealth may mean providing a familiar with the time, the features of the platform.
So to summarize that brief history of that, from 2016 to 2020, that was during the pandemic, right? And a lot of the research and data is from that time. So the studies say who have experienced telehealth during the pandemic, those platforms were not accessible. They were not compatible with video services and interpreting services. So I'll show that furthermore in my slides. And then deaf people must have to call through a video relay service or rely on audio for the telehealth services. Thirdly, what often happens, the quality of the video when in the telehealth with the doctor, the video freezes, or the interpreter translation is not from a qualified interpreter. There's misunderstandings in regard to receptive and expressive interpretation. And that becomes a problem when that information is facilitated between the doctor and the deaf, deafblind, and hard of hearing patient. Those issues come up a lot within the papers, within the stories. And this is why we want to encourage to improve the platforms for accessibility. So I'm going to give you some example. This person is experienced in using the telehealth during the pandemic. They're going to tell you a positive experience with the platform. And I'll show that briefly right now.
I was born deaf and deafblind. I identify myself as deaf and deafblind. I have Usher syndrome type 1, which means I was born with profound hearing loss and progressive vision loss. As I get older, during the COVID pandemic, I engaged in telehealth consultations with my doctor at NIH. My experience overall was good. I clearly could see the interpreters on screen, and an appearance of the interpreter was appropriate. NIH is renowned for their interpreter services. Encountering low quality interpreting in another telehealth session would greatly diminish an overall experience. I would significantly impact my experience. Having a top quality interpreter to crucial for telehealth visits. Contrasting this with my other medical appointments, such as regular eye doctor visits, remote interpreter VRI was provided. I used an iPad to view my interpreter. However, the technology didn't meet my needs. With dilated pupils in a dim examination room, it was challenging to see the interpreter and conduct the eye exam simultaneously. I felt disconnected and uncomfortable during this process. Connection is paramount for me. I faced challenges during this. My doctor, due to my peripheral vision loss, I don't receive visual cues through VRI, like the doctor to grab my attention or things like that. The visual information is resulting in diminished. It's crucial for me, professional level, to present the foster a human connection.
And fast forward to 2022 now. So now many platforms are designed for the general population to prioritize speech and verbal and written English. So now the options can be automatic or live captioned, and they providing high contrast on the platform for visual awareness. And the platforms allow plugins now for videos for the screen. But however, many of the doctors don't, and the physicians realize that that is available. So we still need to educate the providers and educate those health administrators within the system how to use and take advantage of those filters. They are accessible. So now I'm going to show you another example of a deaf-blind person and their experience. Even with those improvements, that person is still on the platform.
Hello, I identify myself as deaf-blind. I utilize multiple types of communication: visual ASL, VASL, tactile ASL, TASL, protactile, PT, text-based English. All of these methods are my preferred modes of communication. I would like to share my experience with telehealth. As a deaf-blind person, I found myself feeling limited with options. The telehealth software I often use, I believe, is Doxy, DOXY.me. Most of the telehealth is on that platform. I cannot remember the specific names of the other software, but there were a few others for my session where I was able to see the doctor on screen. The lack of text option for direct communication with my doctor. I wanted to have direct communication, but the option wasn't there. Consequently, I resorted to using the VRS video relay service via my laptop, which left me feeling disconnected for several reasons. Firstly, my low vision needs. VRS is not the most suitable option for me. Moreover, it's created a sense of disconnection from the doctor. On the VRS in the context, I text to word catering to individuals like myself who prefer text-based communication with healthcare providers. It would be great to add that feature on those software. Thank you.
So to summarize from the lit review, this data is from different. We've done qualitative interviews, surveys, and they've been done by different researchers, not just myself at the center. And we've taken all that data together. So you can see on this graph, the purple represents the perspective of what they're experiencing. The green is deaf-blind. The yellow represents deaf, and the purple is hard of hearing. So for hard of hearing, they appreciate having visual cues in the platform. They appreciate having providers who are skilled in using and understand accessibility. And they appreciate text-based communication, like the chat feature. They feel those are good accommodations for their platform, and they want a platform that can accommodate their hearing aids as well, of getting their healthcare through telemedicine. But however, there's still some challenges that continue to persist in terms of audio quality and the over reliance on verbal communication. Some doctors still just talk and they don't use the chat with the patient when the patient needs it. So that's one, situation that can happen, and we need to educate the medical providers. Another challenge for hard of hearing people, platform is not accessible or not compatible with their other technology, or if they need to put maybe 2 or 3 videos, maybe have an interpreter on the screen or someone for close vision, that's not compatible on those platforms. And also providers not understanding the deaf person's needs. Braille display, all platforms need to be, and for deaf people, it's the approach to interpreters, having interpreters that are not skilled in medical terminology. It's best to have an interpreter who is skilled in medical technology or medical terminology, also making sure that it's compatible with audio services. And the community also appreciates having that interpreter embedded in the, so it makes it easier for eye contact with the provider and with the interpreter. So what the platform needs to do is add a third screen for possibly for a patient navigator or a community health worker who also needs to be on the screen as well. So that way that we can have a holistic care team. Before in the presentation, I mentioned resources that I want to mention again and emphasize, because these are amazing resources that are available to all of you. And this is the North Carolina Division on Deafness and Hard of Hearing. And you can see several what you can do with a deaf person, suggestions with a deaf blind person or a hard of hearing person, and how to make telehealth inclusive for them. And there's tips. Maybe if the captioning stops working or the audio's not working, they offer alternatives so you can continue with the care. This is another story from a deaf blind individual explaining their experience with telehealth.
Hello, I'm deafblind and communication access. During COVID pandemic, I found my telehealth experience to be neutral. When communicating with my healthcare provider using deafblind video phone, the process tends to take longer than it would with an in-person communication facilitator. During my second telehealth appointment, I used a portal, which allowed me to access my medical information, such as my lab results and other reports. However, accessing this information takes longer for me, as I, need to look for the Zoom text display option on Zoom.
So far, you've seen these vignettes and the stories, and you've heard in my presentation. So we know that we have laws in place, but next we need the everyday solutions. And that is the platforms must have captioning. Platforms need to be flexible to allow the user to navigate the screen themselves for captioning or to turn their camera off. It needs to have that flexibility. And the platforms must allow more than 2 videos within the platform. So you can bring an interpreter or a social worker or a navigator to support the patient who may need it. For telehealth platforms, we need to continue to update and make sure we have the experience of the deaf, deafblind, and hard of hearing population. And finally, educating providers on how to work with this marginalized population. And last one, here you go. This is related to making appointments.
I'm deaf and I rely on Facebook portal on my iPad related to my medical issues. Using the portal is user-friendly. It allows me to have direct health care, to manage and discuss my medical history and access records. When I receive appointment, I sent me an email and text, and also to my partner. Why involve my partner? Because this assists me in understanding information that I might miss due to my condition, for instance, hyperlinks, which are often indicated by a different color, significantly or additional information. I can't discern this visual cues, causing me to overlook some of the information, such as medical results or preparation instructions for upcoming appointments. I long for more accessible apps that grant me direct access, eliminating the need to rely on others. My medical information and my needs are solely mine without the necessity of sharing or depending on another individual.
So to summarize the points here today, to make our call for health action for telehealth accessibility, right? That's what this conference is about, is to support that. And I look forward to encouraging the improvement of platforms, but not only platforms, but also improvement at the policy level. And I appreciate everyone's commitment to inclusion here at this conference today. And I'm so proud to be part of the community. Thank you. And I want to thank the people who are involved, who supported these videos. I want to thank everyone here at the Protactile Movement and those who helped make these, and for those people who shared their stories. And Andy, I want to for making this video. Both of them identify right here, as you can see, as deaf. Thank you.
Hi, Purna. Thank you for that whirlwind talk. So, where do you think we can find best practices for ensuring accommodations for impromptu appointments, as such appointments are now widely available in telehealth mobile apps? This is a question from our audience.
Okay. Mm-hmm. Mm-hmm. It depends on the telehealth platform itself. Impromptu appointments depend on the health system. Are they readily able to connect with an interpreter? If they can connect with interpreter services, should be easy. The same as in a hospital. When you go to the hospital for care and you request an interpreter and they bring in an in-person interpreter or a video remote interpreter, that would be the same with the platform. It would depend on the health system and what they have available.
So what do you say to people when they say, oh my God, this is so much work and so expensive. We don't have the money to do this.
Yeah, just we need laws, right? We have to have laws to make it accessible. The law requires it. The US laws have to be made to push that the states are compliant, and they have to make funding available to provide that accessibility. And it really requires a collaborative effort. The onus should not person or the individual. The onus needs to be at a federal level to make those services accessible and available.
How do you think the new rules that came out a couple weeks ago, strengthening Section 504, are going to improve things?
Yes, you just talked about those changes that happened a few weeks ago. This is timely. It gives us the opportunity to focus on improvements going forward. And I expect to see more compliance and increases in accessibility to platforms and a more inclusive environment that allows all of us to develop this. We can get the software developed, and it allows those patients to get the accommodations they need in regards to the video accessible platforms, and it to increase HIPAA reliance and compliance and the use of qualified interpreters. And I expect going forward, there'll be more providers who will have a better understanding of how to work with deaf, deafblind, and hard of hearing people and their accessibility needs. And I believe those are the changes that we're navigating right now.
Do you think that there are any emerging technologies that might things, perhaps with AI or other more recent innovations that can enable this?
I can see the big picture as far as AI plugins in this type of accessibility. For example, in the chat, AI could be used also to connect with others that could be applicable. So those would be really related to plugins going forward. And I see it's happening now, but we have the opportunity in the next several years to see that built into the platforms.
Yeah, that would be incredible. You mentioned education of providers. What does that look like exactly? And how do we disseminate education, given that all healthcare systems and platforms are different?
I see that can be done in two ways. First, implementing medical education in regards to people with disabilities, putting that into actual medical school curriculum. So that will have a wide impact overall for medical students to learn that. Oh, it's frozen. Okay. Okay, we're good. Okay. So really implementing and embedding that in medical school curriculum. That's one. Secondly, making it available also for CME. We have to be responsible for making the content and making it available, educating those in the medical field. And it's important that we include it. And that way we can disseminate to all providers. I think those two are the most impactful ways that we can do that in order to improve education across the board for providers. And of course, there's always webinars, conferences, but those typically are focused on, specific groups of people and as well. But as we want that widespread, I think it needs to be in medical school education curriculum or within the CME classes so it is available for everyone.
Yeah, and it needs to be tested on the licensing exams and also required by accrediting bodies. We just got we got a couple more questions here. One is, what is the risk of providers over relying on virtual and not laying hands on the most vulnerable?
North Carolina State, their Division for Health Services, they have a nice videos that have examples, and I suggest that you take the time to look at the site. One video that they shows a deafblind person using tactile interpretation. So on that platform, it's very visual. And if a person is fully blind, they can't see the screen. They have to have a person there providing tactile interpretation. And that's what you mentioned, the over-reliance. If there's an over-reliance on the platform, that because of them being marginalized, who are already the most neglected population, And it will become a continued barrier and an area of disparity for that group. So yes, thank you for mentioning that.
Another question from the audience is who should we contact if administrators in the facility that you work for are reluctant to supply the interpretation needed for patients? In my opinion, it's difficult to get even in-person patients a translator.
First, in that situation, contact your healthcare office that provides accessibility services. I would contact them to get their help, or legal services that can help advocate for you. If that is not successful, you can contact, if you have an individual that's deaf, you can contact the National Association of the Deaf, and they can provide support for that individual because they provide support for individuals who experience barriers and discrimination. So on the website I showed as well, there's a lot of resources for legal help and advocacy.
Excellent. Well, is there anything else you'd like to share, Purna, before we sign off?
I apologize. I forgot to describe myself visually, so I'd like to take a moment to describe myself. I have dark skin. I have brown hair, shoulder length. I have a shirt on that says Gallaudet University. There's a plant behind me. There's kind of a cream wall in my background. Born deaf, and I was raised deaf. I'm a bilateral cochlear implant user, and I was mainstream. But when I'm in a signing environment, I do not use my cochlear implants. I'm a user of telehealth and also in-person services as well. Thank you for inviting me to present today.
Thank you so much for your wonderful presentation.